Hello, I'm Dr. Ken Landau. Thanks for watching. Let's talk about prostatitis. The prostate's a walnut-sized gland that sits right below the bladder, weighs about an ounce, 30 grams, tends to increase in size as we grow older. Obviously, it's in men only. Issues with the gland are the most common urinary tract problem in men who are less than age 50, and among men over age 50, it's the third most common urologic complaint. Leads to in excess of 2 million office visits every year, creates fluid that goes into the semen. That's 30% of the volume of the ejaculate, and it protects and it nourishes the sperm. It's essential for fertility. It seems that there's a lot of controversy about exactly what is prostatitis, so a consensus development conference occurred at the NIH, National Institutes of Health, in the late 1990s, and defined prostatitis type 1. It was acute bacterial prostatitis, treated with antibiotic, basically cured. Less than 10% progress into chronic bacterial prostatitis or type 2 prostatitis, or another condition called CPPS. I'll tell you what that means in a moment. The chronic bacterial prostatitis tends to be a relatively uncommon condition. It tends to come and go, and it's caused by the same bacteria that caused the acute bacterial prostatitis. We have problems with type 3 or chronic prostatitis, also called chronic pelvic pain syndrome. May or may not be associated with bacteria, typically is not. And then we have the type 4 prostatitis. It's asymptomatic prostatitis. You don't know that there's anything wrong with your prostate. You go over to see the doctor because of an infertility workup, and they find some white blood cells in the semen, or maybe you have elevated PSA and they're continuing their evaluation. Maybe you have a biopsy of the prostate. This occurs, type 4, in 6 to 19% of men and doesn't need any kind of treatment. Now, if you have the acute bacterial prostatitis, that's due to common strains of bacteria, the same cause the urinary tract infections or sexually transmitted infections. The disease itself, however, is non-transmissible. The bacteria get stuck in the prostate on the way from the urethra to the bladder. The condition comes on with sudden onset. It's short duration because you go to see the doctor right away. You have cloudy urine, a urethral discharge, especially when you're having a bowel movement. You have fevers and chills. You feel awful, nausea and vomiting. Because of the swelling of the prostate, there is urinary urgency and frequency and pain. The stream is weak and it's often interrupted. You have genital pain and back pain and abdominal pain. You have pain when you ejaculate. And fortunately, within a week or maybe 2 weeks of antibiotics, all of the symptoms go away. Some people are going to need up to 6 weeks of treatment, but it's not really much of an issue. Easily treated. Chronic bacterial prostatitis is what happens when the acute bacterial prostatitis doesn't go away. This is a much more difficult condition to treat. It lasts for more than 3 months, often up to several years. The symptoms are the same as acute bacterial prostatitis, but they're less severe. They tend to come and go, or some individuals have mild symptoms all of the time. Again, this is a condition that's frequently associated with recurrent urinary tract infections. Sometimes people just develop a biofilm, sort of like a saran wrap inside the prostate, where the bacteria cling and they stay there and they don't get excreted out into the urine. Now we have this issue with CPPS, chronic pelvic pain syndrome, poorly understood, no definitive tests. It's not a venereal disease. It's not linked to prostate cancer. It's not contagious. We don't even know if the prostate gland is involved. But the disease is frequently referred to as prostatitis by the general population and chronic prostatitis by doctors. And the NIH came up with an idea that why don't we call it, for an umbrella term, the UCPPS, the urologic chronic pelvic pain syndrome, and say that the symptoms could occur in men and in women. And as a matter of fact, it hasn't gained any traction, but the same symptoms are present in about 5.5 to 6% of men, and also 2.5 to 3% of women who don't even have a prostate gland. So more issue. Is the prostate really essential to this kind of condition? Same condition, same symptoms as in women. oftentimes in the same family as we have with irritable bowel syndrome or interstitial cystitis or fibromyalgia or chronic fatigue syndrome. And in spite of very frequent visits to the doctor, the likelihood of success in treating this condition is relatively low, and it's especially low if we just continue to treat with recurrent courses of antibiotics because we don't think it's a bacterial disease, at least in the standard sense. It tends to affect men between the ages of 35 and 60, but it seems like teenagers are now becoming increasingly affected with this condition that might occur in anywhere between 6 and 10% of the population. The incidence of new cases, about 0.5% of men every single year. There is significant burden associated with this disease, same kind of burden that we have in our society from low back pain or fibromyalgia or rheumatoid arthritis or peripheral neuropathy. Symptoms are not specific. So you go to the doctor, well, is it an infection? The culture isn't positive. Is it bacterial? Is it associated with benign enlargement of the prostate? Well, with benign enlargement of the prostate, you tend not to have any pain. Prostate cancer? Nah. Overactive bladder? Possibly. Irritable bowel syndrome? Kidney stones? We just have a lot of conditions that this can overlap with. So in chronic pelvic pain syndrome, or CPPS, chronic prostatitis, the symptoms tend to last for more than 3 months. The pain is the thing that gets you. And the pain can occur in one or more areas. It can occur in the penis, typically the tip of the penis, maybe the testicles or the scrotum, the area between the scrotum and the anus. Maybe it's chronic lower abdominal pain or lower back pain, or pain in the pelvis. The pain doesn't tend to be constant. It tends to come and go. And you typically develop pain in the urethra, oftentimes after urinating. This pain can be very mild or debilitating, so debilitating it can stop you in your tracks. It can radiate to the back, it can radiate to the rectum, it can make sitting or standing very difficult or even uncomfortable. And all of this without any evidence of a urinary tract infection. People develop voiding difficulties in addition to the pain. You can develop swelling of the prostate perhaps, develop frequency where you go to the restroom at least 8 times a day with a weak or an interrupted stream. Oftentimes the bladder begins to contract when it isn't even full. And that leads to even worse problem with the urgency and the dribbling and the hesitancy and getting up at night to urine. And it leads to sexual dysfunction in about half of the men who suffer the condition. Erectile dysfunction, decreased libido, which then goes on to a decrease in the quality of life. And then that goes on to anxiety and depression because you're obviously suffering from something, but nobody can come up with an idea as to what you have. And then that leads to unexplained fatigue and a lack of energy. Well, the symptoms basically fit into a basket. One is pain, another is voiding difficulty, another is sexual dysfunction. So the diagnosis actually is a diagnosis of exclusion. We rule out all of the other problems. Now, one of the factors that makes this all the more confusing is the urinary tract under general circumstances, under routine circumstances, is not sterile. And because it's not sterile, we say every time we find an organism, well, maybe that's the cause. Well, there are lots of organisms, but most of the organisms in the urine in otherwise normal individuals, and even those people who have chronic pelvic pain syndrome or CPPS, those bacteria don't show up on routine culture. We need special kind of cultures. Could they be at least in part responsible? Don't have any idea, at least no good evidence at the present time. So what's the theory of the disease? The theory is that maybe you had an infection, maybe you had some pelvic trauma from sports or from bicycling or horseback riding, or maybe some other kind of a similar problem. Maybe you had a catheterization or a prostate biopsy. So in young or middle-aged adults, we start seeing these kind of symptoms, and the symptoms tend to begin with something wrong apparently in the periphery. But over a period of time, it seems to migrate to the central nervous system, to the brain. The brain becomes involved, and then you don't need anything in the periphery anymore. So now we have a very difficult, very confusing situation in order to try to understand. And then we have the stress hormones that some people think are abnormal in individuals who have this condition. Some people think that the bladder talks to the gut, that talks to the brain. And then that leads to the problem. Well, in order to better define the condition and to sort of gear our treatment to one area or another instead of just the shotgun antibiotics, some people from the Cleveland Clinic in about 2009 came up with the idea that we could categorize the symptoms in 6 different buckets. Later they expanded it to 7. So it goes by the mnemonic U points. U points. The U stands for urinary symptoms, the P for psychological problems, the O for the problems specific to the prostate, the I for infectious causes, N for neurobiological dysfunction, those symptoms like the irritable bowel syndrome and fibromyalgia. And then the T is for the trigger point or muscle spasm, and the S is for sexual dysfunction that affects, as I mentioned, about half of the people with the condition. In only 20 or 30% of men, the symptoms are limited to one domain. Typically, they're in multiple domains. The urinary symptoms occur most frequently. The infectious symptoms occur least frequently. And then they came up at the NIH, National Institutes of Health, with the chronic prostatitis symptom index. Now, unfortunately, the symptom index, the score on the symptom index, it's just a little test you take, a multiple choice test. And it comes out so that the results of the score of this questionnaire don't seem to have any specific correlation with the inflammation or with the histology in the prostate, but at least we can follow along the severity of your condition. It asks 9 questions about the pain and urinary symptoms you have and your quality of life. Do we have any tests for the symptoms? No, no tests. There's a lot of urinary cultures that are going on. They don't show anything. There's digital rectal examinations. Again, doesn't show anything. Prostate massage doesn't seem to be very helpful. No abnormalities found on either the blood count or the PSA. People don't have discharge. They don't have enlarged nodes. So the question is, how do we go about treating this other than with the antibiotics all of the time? Unfortunately, the best we can do seems to be education, stress reduction, perhaps some behavioral changes, and some advice to avoid prolonged sitting or sit on a cushion or take a sitz bath or modify your diet. Don't do anything that's going to irritate your bladder, for instance. Try to avoid alcohol and cigarettes and caffeine and spicy food. Maybe see an acupuncturist or get some chiropractic. But for those who have the condition, we try to minimize the symptoms that the people are having. And we can minimize if the urinary symptoms are prevalent, maybe with medicine that we would use for benign enlargement of the prostate, or medicine like Flomax or Rapaflo or Uraxatrol. They relax the smooth muscle in the prostate. Antibiotics, unquestionably overused. There's no role for antibiotics on the overwhelming majority of people. And people who take the antibiotics, course after course after course, have zero chance, basically, of getting better. It does not appear to be a problem with infectious diseases. An inflammatory disorder? Well, a lot of people take the nonsteroidal anti-inflammatory drugs, aspirin or relatives of aspirin like naproxen or ibuprofen. But the amount of improvement is relatively small, and there's no good supporting evidence for other drugs. Certainly the opioids are not appropriate. There's no evidence for Lyrica. Other people use chondroitin sulfate, or they alkalinize the urine, or they use some bioflavonoids, or flower pollen extract, or quercetin, or saw pimento. All of these are just grasping at straws. There's no evidence that any of them are specific for the condition or provide any significant useful benefit. Some people have tried therapeutic ejaculation. At least that appears to not be harmful. And it certainly is better than the prostate massage that some doctors still advocate. Actually, in the 1800s, it was thought that masturbation was probably a cause of this condition. Well, a lot of other things have been prescribed, the Avodart and the Proscar, and even the same kind of treatments that we would use to treat kidney stones, but none of them seem to be terribly helpful. So it gets back to a condition where we have lots of treatments, but we have very little understanding of what underlies the abnormality. What is the basic cause of chronic prostatitis? And is the prostate actually involved or not? We know that over a period of time, the condition tends to stabilize, but we don't really understand whether it's a disease of the prostate, it's a disease of the central nervous system, it's a disease that's sort of in the functional family, where we would find irritable bowel syndrome. You have to remember that once upon a time, we thought that stomach ulcers were due to an excess production of acid. Then we find out bacteria was involved. Is it possible that we can find a bacteria is involved in this condition? Sure it is, but at least at the present time, we don't know what the bacteria is. But we do know our chronic antibiotics, the kind of antibiotics that we have now available, don't seem to be very helpful. So what's the most we can do? Education, the realization for the patient, for the individual with the condition, that it's not a serious disease, it's not a cancer, it's not going to affect the overall health in the long run. And hopefully, we'll find out what the underlying cause is in the relatively near future. Anyway, thanks for watching. I'm Dr. Ken Landau.